Hello, everyone. My name is Dario Englot, and I'm a functional neurosurgeon at Vanderbilt. This is the FAANS Leaders in Neurosurgery interview series, and I'm extremely honored today to be interviewing and speaking with Dr. Pete Konrad here at West Virginia University. So, Dr. Konrad, thank you so much for taking the time.
Absolutely, my pleasure, Dario.
So I'll do a little bit of a formal introduction of Dr. Conrad and then say a few words. But so Pete Conrad, MD, PhD, he did his graduate degrees from Purdue University in biomedical engineering and physiology. And this was work developing device technology for cardiac implants for his master's and then motor systems physiology for his PhD under a Presidential Medal of Technology awardee, Dr. Geddes. He became interested in medical device technology quite a while ago, neural engineering, and then he sought to become a neuroscience and neurosurgical expert in the field. Dr. Conrad did his med school at Indiana University in 91 and then moved to Vanderbilt for neurosurgery residency, finishing in 97. And then he spent the next 22 years of his career here at Vanderbilt, where he grew one of the largest clinical programs in deep brain stimulation and functional neurosurgery. Dr. Conrad moved to Rockefeller Neuroscience Institute 4 years ago now in 2020 as the J.W. Ruby Professor of Neurosurgery and Neuroscience. And at that time, he was the executive director for clinical translational neuroscience, where he was working on leading clinical trial research. Then Dr. Conrad transitioned to the position of chair of the Department of Neurosurgery at West Virginia in April 2022. Overall, Dr. Conrad has mentored over 40 graduate students and clinical fellows in all areas of neural engineering and neuroscience research. He's got 25 years of experience of federal and industry funded research, over 130 research publications that are peer reviewed in the field of functional neurosurgery and neuroengineering. Also, Dr. Conrad served as an advisor to the Congress of Neurological Surgeons on medical devices and was a board of director for the American Association of Stereotactic and Functional Neurosurgery, so ASSFN, our functional society. After 18 years on the board of the North American Neuromodulation Society, or NANS, he serves as the president of that society for 2 years, from 2020 to 2022. On a personal note, Dr. Conrad is my fellowship mentor who recruited me to Vanderbilt 8 years ago now to serve under him as his fellow, and then was very generous to recruit me to stay on as his junior partner. And so I got a year of fellowship and 4 wonderful years of mentorship from Pete, and we've become good friends. And he's someone that I look up to so much, and really just an inspiring leader in this field, but also just an amazing person and someone that I aspire to be like, both on a personal level and a professional level, and just extremely dedicated to service. So again, thanks so much for doing this, Pete. This is great.
Absolutely love to, Dario, and always love chatting with you about anything related to any of the topics you want to talk about. So let's talk.
So you're a leader in functional neurosurgery and now in organized neurosurgery and neuromodulation, and now leader of a department. But you taking a step back, can you tell us a little bit where it started when you decided you were going to be a neurosurgeon?
That actually goes back a long way. In my childhood, I always liked challenges, and I was very interested in medicine. And I didn't know it was called functional neurosurgery at the time, but I knew I had to get involved in something with medicine and technology. And that process really didn't formalize in my brain until I kind of was aware of an MD PhD program where I could do both engineering and medicine together. And so I tried the hat of being an engineer first under some advice from a great mentor I had in college who said, if you really want to do the research piece, you ought to explore that first, because you can do the medical school piece, but that's a different world. And so he connected me with, as you mentioned, Dr. Geddes, who was just I mean, he was by far my most informative instructor and mentor in science, as well as Willis Tacker, who was my graduate advisor then, but the two had run the bioengineering department at Purdue. And after I got there for my master's degree, I knew I wanted to do neuro, but they didn't have a program funded in neuro at the time. They had one in cardiac, so I took it and loved it so much there that I said, I want to stay here for my PhD first.
Right.
And and I'll go to medical school here in this state just to stay here for my graduate program. And so I applied to IU and made both programs work. Actually, I was an inaugural person between both universities, Indiana and Purdue, as a bridge person who did medical school at IU and graduate school at Purdue, sort of in a dual program. There was kind of a novel program that I shared with one other person. But anyway, that got me then started in thinking about applying neural engineering and technology to medicine, and then obviously functional neurosurgery was the place where people of my kind basically assembled in neurosurgery and talked about these things. Although that was in the 80s, there were no real neurologically implantable devices of any report, except maybe a few stimulators at best for pain treatment, but those were not really standardized at that time.
Right.
So that's kind of how I got into it.
Yeah, it's funny when you say you didn't know it was called functional neurosurgery. The term wasn't even really used yet. So, which is kind of the timing that you got into this field was at a time really when things were starting to come together for neuromodulation. And how did you make that transition from when you decided to stay at Vanderbilt, leaving residency without a real functional neurosurgery program yet, without a deep brain stimulation program, really, because the technology was just really coming out, and without really having that mentorship in residency. Now oftentimes we have that mentorship, and we aspire to be like some of our attendings where we see ourselves doing similar cases, but you really had to build that from the ground up here at Vanderbilt. And so how did you make that transition to from basically not having a program to over the next 22 years, building as big of a functional neurosurgery program as Vanderbilt became?
Yeah. So in a nutshell, I mean, it's a collision of right people, right places, right environment, right? So you cannot do that if you're at the wrong place in the wrong time. Vanderbilt was a right place for me because my requirement in looking for a job as I was finishing residency was someplace who would give me an opportunity to grow my engineering interests as well as my neurosurgery interest. And Dr. Allen was the chair at the time, and Bob Galloway was on staff here, and it was a no-brainer for them to offer me the opportunity to mentor graduate students, because that's really a pathway that you share with me, and that is like graduate students are an important pillar if you really want to head into some serious bench work in science and not just clinical work. So that opportunity came out as I was looking for jobs at the end of '97. But what was happening also was David Charles at that time had accepted a Fulbright fellowship over in Grenoble and was spending time with Dr. Benabid and Dr. Pollock, the neurologists there, and came back to our department, presented us with Dr. Benabid's notion about why DBS is going to be the next best thing. And it was just approved in the fall of '97 when I was finishing. So the FDA had just approved it, and so no sites were really up and running as major sites other than the ones who did the original research. And we were part of that program at Vanderbilt, among many who were exploring DBS as a research opportunity, but then it became FDA approved, and now there was an obvious path for that being a standard clinical offering. Okay, not research, but a standard clinical offering. So David came back and said, I need someone who's really going to devote their time to doing these implants and really gets it. And obviously this was something I was in. It's a device and technology. And so I said, I would really like to take that program with David and grow it. So it was just David, Charles, and Tom Davis and I. And then we started having a conference after a year. And then the three of us started talking and meeting every so often. And some patients started coming in. And the first few years of DBS, I mean, it was a few patients a year. It wasn't anything like it is today.
Sure.
As it was just approved. And you have to really, first of all, then see if the technology really is what it's claimed, and we were seeing people really getting some benefit, then you can really believe that there's a path that's going to scale up from there. I mean,
Yeah.
you have to envision scaling. Scaling's been an interesting engineering problem over many years. It's there are many carcasses on the road of discovery to scalability and full-time, full-blown treatments that are adopted everywhere, because scaling is not a minor challenge. So this was a scaling problem for the world and for us at Vanderbilt in particular. But we started having more meetings, and then more neurologists started showing up, and they bought into the idea that DBS was a very viable option to treat Parkinson's disease and tremor. And then we just started growing. And once you have the belief of a team that it's good therapy, then patients start, inquiring, and the program continues to grow. And then you have to stay ahead of coding, billing, reimbursement, making sure the institution is solvent with the program, that, it makes sense for the environment to also grow with it, and that all kind of fell in place. It's not an easy job by any means. It took 20 years to get to the place we were at when you were inquiring as a fellow.
Right.
So it wasn't easy. So patience and persistence definitely are needed.
For sure. You make it sound easier than it is, though, almost like you just put together a team and things come together. But it's really not just a great team. It's really one of the best in the country. Even now, every week I see a DBS patient and I say, you'll be in good hands with our team. We're within the top three in the volume in the country with how many of these we do. So it's not everybody was able to scale it to the level. And I still you've got this functional neurosurgery shared folder with a lot of your old presentations here that sometimes I like to go through, and some of the presentations you showed over the first 10 years, 15 years, just the increase of the program, just adding a second surgeon, adding a third surgeon, growing your movement neurology team from a couple movement disorder neurologists to, I think we have 12. Epilepsy, from a couple of adult epileptologists now, I think also around 12. So it really is impressive. So there's got to be, I don't know, is there some secret to when you say team building and working with people that you have that you find most successful in getting people to come line up behind you and get on board?
Yeah, I think there's a couple things you have to have. Again, it's the merger of several processes, but first of all, you got to have the right culture. So, and what do I mean by culture? It means that you have to have a team that is affable and workable together. If you have people who are on separate agendas, that they're not either emotionally or intellectually incentivized, forget the financial piece, then you'll never build your team. If you can't align people around a vision. So again, it's developing the art of creating vision. And vision needs to create a winning strategy for everyone, not just a few vested people. So if a program only benefits the surgeons and not the referring doctors, I promise you it will never grow.
Sure.
If the program only benefits the physician's billing line and not the hospital's billing line, the program will never grow. So as you're growing programs, you have to have a really good sense of the stakeholders and what's in it for them. And sometimes that aligns, and then a few years later, you find out it doesn't align. And then you have to make some decisions, like do you course correct or do you abandon that part of your vision?
Sure.
And so it's never a static thing. At any moment, you can lose a winning strategy by the people either not buying into the vision anymore, or the facilities and the infrastructure not buying into the vision anymore. Then you're back down to nothing. Or if a technology gets outpaced or stripped by something else, you may have a great vision, but it's no longer, like I said, then you lose the stakeholder of the payers and the infrastructure, because they're not going to support that anymore.
Right. Yeah. It takes a lot to build something, but I think it probably also takes a lot to leave something and do something else, right? So that was, you were after 30 years at Vanderbilt, including residency, 4 years ago, you made a pivot and decided to go to West Virginia first to lead the translational clinical sciences, the center there, and then obviously to not knowing you'd be chair at that time, but then moving into that role a couple years later. What's it like after spending that much time, building something to just say goodbye to it and then go do something else?
Yeah, it's hard. It was hard. We had a lot of talks about this, and I think leaving a great team behind is not easy, but it's a lot easier when you got good people you're leaving behind. So it's one thing to just exit a program and realize it's probably going to collapse because you're the only one who cares about it. If you've left people behind who care about it, then you're just planning another opportunity to keep the process going. So you and I have talks about these issues all the time. How do we how to keep the program going? I think it's a healthy maturation. It afforded you an opportunity to grow professionally and career wise. So not all exits are always a negative for everybody. Everybody has a chance to grow, and I've learned that in more leadership opportunities that in today's world, we were just talking about this with some of the other faculty and leaders recently. A big change that people don't realize that has happened in the last 10 to 15 years is that people nowadays do not look at careers as 10, 20, 30-year commitments like I did. Like when I took on doing an MD PhD, my dream and goal was to find a job where I would just be there and, retire out there, which was sort of where I entered Vanderbilt in that mentality. But the world changed, the environment changes, and you realize that in order to continue doing what you like to do, you actually have to evolve and change. You have to evolve and change. In today's world, people look at, I think, reasonably 3 to 5 year snippets of their life and then reassess and figure out, well, am I still doing what I need to do, or do I need to change? And that used to be a bad word when I was coming through. You never wanted to see people leave their job too much. It is a fact of life today, if you're in the business of hiring people or working with people, that people rotate a lot. And nowadays I've learned not to be disappointed when people tell me I'm going to move on to something else.
Yeah.
My only concern is I just need time for the transition to happen smoother than abruptly. And I actually encourage people to continually grow and evolve because that's the natural progression of people maturing in their careers. So it isn't a bad thing anymore for me to think about evolving and growing. I've certainly learned a lot from a chair role that I never would have gotten before then. And I understand, I'm in a process now that's different than Vanderbilt. Our health system is a system of 26 hospitals.
Yeah.
So right now for me, what I really enjoy about this job is thinking about neurosurgery and functional neurosurgery and just neurosurgery in general as a system problem for an entire state, not just, a hospital that is trying to develop a top level service for one thing in particular, but it brings out a different aspect of being a doctor and a neurosurgeon. I've stopped doing disc surgery and spine surgery a while ago, although I did a lot of that. But I still think about, what does the average person in a community of 10,000 people need a neurosurgeon for compared to what we think of at a tertiary center. Like if you've got an acoustic neuroma, well, then who's the best place to do an acoustic? But if you're designing a health system and understanding neurosurgery at a state level, you realize there's this whole gamut of care that impacts neurosurgery at different, like trauma management in our state's a challenge. We have a lot of mountains. It's not easy to get around. We have one major tertiary center in our system. How do you get people to appropriate levels of care when that's a challenge, versus being in the middle of Nashville, 3 health systems, or Chicago or New York? That's a different challenge. Sure. So, I'm still growing, but in different ways. And I still love functional and I love devices and technology, but there's opportunity for me yet to grow in different ways that I didn't think I would be interested in.
Yeah. Talking about how the technology is changing, and it really is kind of incredible. I'm sure from when you started the program here at Vanderbilt, with how different things are in functional, meaning DBS was still, as we said, obviously wasn't even a thing yet, except for the few places that trialed it in the studies. Now we've got closed loop studies. We've got obviously this directional stimulation. We've got image-based programming. On the epilepsy side, we had grids, resections, and disconnections, and now we've got neuromodular brain stimulation, open loop, closed loop, thalamic stimulation. We've got laser ablations. We've got stereo EEG. Is there anything that surprised you about watching the field evolve over the last 20, 25 years?
I think, again, this is kind of a generational observation, not necessarily geared to one technology or another, but um, a statement about technology evolution. I still believe that we are in a bad divergence in what healthcare technology offers our patients today as FDA approved payable services technology wise, and what we are discovering in the lab.
Mm-hmm.
So what I mean by that is, if you look at our DBS implants today, as nice as we think they are and sophisticated as they are, and they have sensing and closed loop and rechargeable batteries now that are much better and stuff, that is really not breakthrough technology. That was around 20 years ago in rats.
Sure. Yeah.
We basically, still have a problem with deploying technology quickly and effectively. And we sort of still have a big problem in this country with rapid adoption of technology. And the curve is only getting further apart. What you're seeing in the lab and companies doing and developing now with AI and all the stuff that's showing up, even from investors like Elon Musk and Neuralink, that technology is so different than what the average patient today gets to have. There's a bigger problem than just the technology. To me, it's an access problem, and it's what society and culture has to change in our country. And so understanding that, I think, is still an issue, but we'll still see good things happen from that. But the other observation I was going to make about last 10 or 20 years is that patients, I have now come to believe, as a chair especially, that neurosurgeons need to continue to be forward looking in what services patients and payers want to receive from us.
Yeah.
Days in which we view neurosurgery procedures as technically big, long, complicated cases and things that only somebody who's skilled with 7 years of advanced microsurgical training. Our patients really now don't care about that as much as their experience and their encounter has to be. They're assuming it's safe. Now they're wanting to just go home the same day or the next day. So I think my message to all the next generation of neurosurgeons is, you've got to get good at doing things in which patients go home the same day or the next day, because the hunger for staying in a hospital 4 or 5 days or undergoing a large open procedure, whether it's spine or cranial or whatever, will continue to diminish. And we have to get better at offering short, safe, outpatient or short-term stay procedures. That curve is going up. I did a survey of this with our group when we got here, and when I started here, about 30% of our surgeries were what I call early discharges within 24 hours. And, because as a leader, people are asking me, like, what's your strategy for the next 5 years? And I said, more outpatient, shorter surgery. We're going to be half or more of our surgeries, I believe, will be done with people going home the same day or the next day. This is a scaling problem of how do you move people through safely and effectively with shorter procedures and still effective, safe outcomes. And that means how do you develop good outcome protocols, measures of productivity that the public will rally around and the hospital understands as a core mission and payers understand. Payers are the one driving this. The patients are the one driving this. And we have to get on board with that. I think a lot of neurosurgeons are doing that, but I mean, the message here is not to go learn big, long surgeries that take days of recovery in the hospital. The message is adopt things like look what LIT is doing for epilepsy surgery, even though you and I love doing mesial temporal lobectomies, technically, you know that the number of those are just going to be going down if there's an alternative that has an equal outcome. Now, you could debate about how well the outcomes are between any two given therapies, but if they're anywhere close and one is a day outpatient and the other one's 3 days in the hospital, that's not going to be even argued at the surgeon level. That will be argued by the payer level and the way the patients flow. So you can't ever stick your head in the sand and just say, I learned it this way when I was a resident 10 years ago, and I'm really good at this, and that's the way it's always going to be. We have a whole history of where people have gone with that and are no longer practicing that. Take a look at aneurysm clipping. I mean, that's a lived story for my lifetime. I was trained to open clip aneurysms, and I loved doing that when I was a resident. But I would be remiss if I was taking care of a patient and they had an aneurysm come in, and if I didn't know endovascular procedures, that patient's care is not going to be ideal.
Sure.
Nowadays, no one would argue that you have to do both. You have to be good at both. So I'm just saying you got to be thinking about technology in the direction of shorter and less managed or complicated.
Yeah, that's where things are going. That's where I agree with you. I've got a question that I should know the answer to, having trained with your fellowship for a year and learned from you a few years after that. But I was thinking about it today. I don't actually know the answer. And what if you had to just pick one? What's your favorite surgery and why?
Oh, yeah, that's a pick one favorite surgery.
Yeah, your favorite neurosurgery procedure. If you had
all
to.
Right. So it was a hemispherectomy.
Yeah. Okay.
Which we stopped doing, I mean, there's not that many hemispherectomies that are done, but when you learned it, that was the reason I love that surgery. Again, it was an example of a major surgery that took a long time, and people would say, but it was pretty good outcomes in kids that had, Jacksonian types of problems or, infantile spasms or all kinds of, reasons for doing a hemispherectomy. But the reason I liked it was because you got to see the entire anatomy of the brain in one surgery, just about. I mean, if you do that surgery right, the way it was done originally and described and talked about, a functional hemispherectomy versus anatomical hemispherectomy, that was an amazing procedure, and children did very, very well with that. That had a great outcome. But today, my partners actually can do that with LIT, and fairly well placed LIT will affect the same thing. Can't make the argument that a hemispherectomy is indicated hardly anymore.
Yeah, well, so like you said, things are evolving to shorter, minimally invasive, but hopefully equally effective procedures. Before we started the recording here, you were telling me about some fires that you were putting out, and obviously life as a chair is busy. But tell me, how do you achieve work-life balance, and what advice would you have to some of the younger academic functional neurosurgeons coming up the ladder? They want to build a resume, they want to climb the ladder, but they also, want to have a life. Do you have any advice about that?
I think, this is always a struggle because our society now is accelerating at such a higher stress load and pace. I think to today, to have a better, and no one has a perfect work-life balance. If you're a neurosurgeon, you are by your nature a type A personality and committed to an extraordinary amount of care for your patients. So you're sort of always married to the job of neurosurgery. But what you want to do is schedule in times where you can take a break from the fast-paced world that we all live in. And I think it's imperative when I get personally feel like I'm drowning and stressed on stuff, there's usually two things that have happened or are happening. One is I haven't really looked at or managed my calendar effectively enough in advance. Mm-hmm. So I've gotten to a point where I'm reacting hour by hour or day by day to the next incoming missile, and I have not had a chance to look ahead and say, okay, this is the week I'm off, and I just got to make it to then. And then I will reset when I come back. So that I would stress is like something really important people have to do is just, I tell all of my faculty now in junior faculty, use your administrative assistants if you have the luxury of that to sit down once a week and plan out your calendar for the next few weeks so that you can be more effective at managing your time, because our time today is so compressed. When I go home, I do not like to drag a lot of work in at home. There are times we have to do that. But again, it's scheduling time to take a break from your work and sure. where you can mentally switch out of the work mode and put yourself uninterrupted with your family. And I think our spouses and our families deserve not us, okay, honey, I'm looking at these texts and stuff like that. That is not fair to them. You have to literally let it go and give them the time so that you can reset with them and then come back to work refreshed. You really are a more effective person when you take that break.
Yeah, for sure. So I agree with you. In our field, though, no one really fully achieves that work-life balance. It's just not possible with what we do. But you got to have some outlet for sure.
Yeah. Well, I think being smarter about scheduling it in, right. Scheduling breaks in, is probably the best way we can do it.
Get it on the calendar, get it in. Yeah. Really, just one more question, and I know you're a humble guy, and you're not someone who probably thinks about your legacy much. But the truth is that you will have a legacy because you've made some really incredible contributions to the field, both in terms of building a functional program, leading societies, guiding societies, now leading a department, your research in neuroengineering and the research programs that you've built, the projects you've done. What do you think you'd want your legacy to be, and what would you like to be remembered for?
Yeah, that's a really tough question.
I know, that's why I saved it for last.
But no, I think any of us in this position who have people we've trained and mentored, in the end, you realize the legacy is really carried on in the people you train. And so, I really would hope that, the things that I have taught you and others are just kind of continued with the culture, not necessarily the technical prowess or anything else, but the culture and the curiosity of being a good, investigative person with your patients, not just teaching you how to take care of people, but ask good questions about generating the next discovery or the project that will carry on, the solutions for people in the next generation. So, I like to think of myself as somebody who balances clinical and scientific inquiry. And to me, the two are connected. You can't be a good clinician without asking, why is this disease not fixed? Or why are we still struggling taking care of pain, or facial pain, for instance, or whatever. And that prods you to be a good scientist if you have the mindset to say, okay, what is actually the questions that need to be answered to drive that answer to the next level for your patients? And your patients actually motivate you to be a good scientist, I think. So
Yeah.
when we talk to MD, PhD people, and they want to know how you balance a PhD and clinical work, I said, just marry your interest in both, and both of them will drive you to do good things. And so, I would hope my legacy is to get people to be better scientists because they're good doctors, and better doctors because they're good scientists.
Right. That's great. Yeah. I think, like you said, the way you influence other people and the way they continue your work and is really how how your legacy really evolves, even after we're gone. So I think I really appreciate you taking the time for doing this interview. Even more so than that, I appreciate all the things you've contributed to our field. I'm sure people are going to really enjoy watching this and hear a little bit of your words of wisdom. And then most of all, I just want to let you know how much I appreciate your mentorship and friendship. And I know so many people that you've mentored and guided. Appreciate it really. And thanks for always being there.
Yeah, well, thank you, Dario, and I know we'll have many more great talks coming up. So
Thanks, Pete. All right.